Hello, everyone. I'm delighted to welcome you to the Medscape Live social media broadcast today on NF1-Associated plexiform neurofibromatosis and neurofibromas, community insights with key questions, and we'll try to provide expert answers. My name is Matthias Karajannis. I'm the chief of the pediatric neuro-oncology service at Memorial Sloan Kettering Cancer Center in New York, and I'm delighted to also introduce my co-host, Dr. Cynthia Campen, who is a clinical professor at Stanford and the co-director of the Children's NF program. So today we are going to be talking about plexiform neurofibromas arising in NF1 patients, and as opposed to cutaneous neurofibromas, which are typically smaller and more circumscribed, plexiform neurofibromas that arise in NF1 patients are typically larger, more diffuse, and often located in deeper structures of the body where they may or may not be visible. Neurofibromas arise from Schwann cells. It is a stepwise process whereby a Schwann cell that experiences a second hit in the tumor suppressor gene NF1 may start to form a tumor, initially a plexiform neurofibroma. And in some patients, over time, and that can take months to, in many cases, many years, there can be a stepwise progression towards malignancy with an intermediate step called a atypical neurofibroma. Often these have acquired additional mutations, specifically in the tumor suppressor CDKN2A. And then further along, some of these tumors may progress to frank malignancy, and these tumors are then called malignant peripheral nerve sheath tumors. And part of this process includes alterations in epigenetic regulator genes shown here. So the clinical challenge is how to take care of these patients, how to manage the tumor symptoms, and when to intervene. And specifically, that means, when should we consider to recommend initiating treatment that is tumor specific in these patients? So one key factor, of course, is the symptom severity, meaning that this decision is driven whether symptoms are present. Pain and cosmetic concerns can be primary treatment motivators in many patients. It is important to consider the tumor growth, including the tumor growth rate. Typically, these tumors tend to grow faster in younger patients, and the growth slows down as the person gets older. And then, of course, the extent of the tumor, the size of the tumor, and the tumor location, depending on the anatomical locations, these tumors may have very different symptoms or present different clinical problems. And as I mentioned, rapid growth is typically seen in younger patients, and the natural history, which is important to consider, is that typically slows down growth. The growth slows down during adolescence and adulthood. So all of these factors are important to consider when to think about treatment. The key research over the last approximately decade has identified the signaling, the molecular signaling associated with loss of neurofibromin, or NF1. And primarily, neurofibromin inhibits RAS. And that means that when neurofibromin is lost, the cells go into signaling overdrive based on the disinhibition of RAS, which leads to activation of downstream signaling cascades, and most prominently the RAF-MEK-ERK signaling pathway, which promotes cell growth, survival, and proliferation. Drugs have been developed that inhibit the MEK kinase, which is shown here. And this interrupts the MAP kinase signaling pathway that is overactive in cells that have lost neurofibromin. And as a result, this can reduce the growth of tumors and or induce tumor shrinkage by specifically targeting the signaling pathway. And a number of MEK inhibitors have entered the clinical realm over the last years. And one of them, selumetinib, is now FDA approved for the treatment of pediatric patients with NF1-Associated plexiform neurofibromas. As you can see here, several other similar drugs, also MEK inhibitors, are currently in phase 2 clinical trials, some of which have already been completed and preliminary results have been reported. And all of these drugs seem to have an anti-tumor effect against plexiform neurofibromas. And so in clinical trials, including selumetinib, significant tumor shrinkage has been observed, not in all patients, but in a subset of patients. And there is a spectrum of responses from ranging from stable disease or stable tumors to minor responses to more prominent responses. And notably, there has been success not only in regarding imaging responses, meaning tumor shrinkage and improvement of tumors appearing on MRI scans, but also clinical improvement that is seen in patients, including reduction of pain. And that is very important because many patients with plexiform neurofibromas experience difficult to control chronic pain. MEK inhibitors have also led to or been associated with functional impairment that has been studied in clinical trials in terms of, for example, range of motion, mobility, and other functional outcomes that are important and that are often impaired by the presence of plexiform neurofibromas. Now, we're going to discuss MEK inhibitors and surgical considerations. And so we heard that MEK inhibitors can reduce tumor size of plexiform neurofibromas, and that, of course, brings up the question, could this also help making surgery easier and or maybe sometimes obviate the need for surgery? And I would welcome to hear from you, Cynthia, about your clinical experience in terms of how have you seen patients whose tumor size was reduced by MEK inhibitors so that surgery became easier for you? Or have you had patients that you thought were surgical candidates that wound up not needing surgery, or ultimately you weren't recommending surgery because the systemic treatment worked so well?
It's such an interesting question, Dr. Karajannis, and I think that the practice has really evolved over the last 5-6 years as MEK inhibition has become more available for our patients. And what I note, 10 years ago, what would have been an operable tumor, according to the surgeons, now they're sort of backing away and saying, well, why don't you try medical management first, since we have an effective treatment? So I really think what we're naming as a surgically amenable tumor is evolving over time. But certainly I've seen tumors that have been approaching or exerting mass effect on important structures that we initiated MEK inhibition prior to consideration of surgery, and found that there was enough shrinkage away from those structures, those important structures, that we didn't need to introduce surgery. we haven't studied prospectively looking at MEK inhibition in advance of surgery to see if that improves surgical outcomes. But that's an interesting next question, I think, for the discipline.
Excellent. Thank you. And I was wondering if, there is any data or perhaps preliminary observations on, do the tumors change under treatment in terms of, does it make surgery, even if the tumor, if you don't consider the tumor size itself, but the tumor composition, if you will, does that change? Is there any data or any experience that surgery becomes easier or more difficult? I'm thinking about sort of similar, experience with neoadjuvant chemotherapy, where it's not just about shrinking the tumor, but also making them perhaps less vascular and easier to operate on. Is there anything regarding this that is known for MEK inhibitors?
That's an interesting, and I similarly was thinking it from the neuro-oncologic perspective, in particular with ependymoma or other tumors where we can see decreased vascularity, we can see improved plane between tumor and normal brain tissue. I'm not aware of that within plexiform neurofibroma specifically to date, but you could certainly think about that as a potential and a possibility.
Great, thank you. And I think all of these points highlight the need for close collaboration, right, between the oncologists or neurologists and the surgeons to really come up with a tailored plan, short-term and long-term, in terms of multidisciplinary management of the symptoms of NF patients. Now, here we are going to focus on considerations for treatment discontinuation with MEK inhibitors. We have learned from clinical trials that while sometimes responses are early, they can also be late. And this is a treatment that is if you will, a chronic treatment, and tumor improvement and improvement of pain can take a while. And the improvement can be increasingly sustained with continued therapy. And then the question comes up, when to stop therapy. It has become clear that tumors have the potential to regrow after cessation of therapy. And so if the decision together with the patient and the family is to try to watch and see after discontinuing a drug, it becomes important, of course, to follow symptoms closely and or imaging to see whether there is regrowth or not. And what factors into this, of course, is the natural history that we discussed. So the age of the patient, how quickly has the tumor been responding, how deep was the response, or perhaps it was only stable disease. So I think all of those considerations go into the decision making. And so the symptoms we need to watch very closely. If needed, treatment can of course be restarted, and so it will have to remain a very personalized recommendation as to when to stop and potentially restart therapy. So now we're going to talk a little bit about toxicities of therapy, which at this point are very well known and described. And of course, every patient is different in terms of experiencing side effects. Some of it is associated with age. And of course, if there are existing conditions or morbidities, those may also contribute to the toxicity profile in an individual patient. So the most commonly observed toxicities with MEK inhibitors, including selumetinib, are shown here. So GI side effects are quite common. Skin problems also common in patients with pre-existing skin problems such as acne. Those can become even more relevant clinically and clinically challenging. If feasible, it is ideal to have a dermatologist be part of the treatment team, and ideally assess the patient before, during, and after treatment with MEK inhibitors. There are many preventative interventions that can be done before and during treatment to minimize the risk of significant skin toxicity, especially skin toxicity that would necessitate to stop the drug, at least temporarily. And other common side effects include muscle and bone pain. Elevation in CPK is quite common. It's typically not a reason to discontinue therapy, but it needs to be monitored. General symptoms such as some fatigue, some occasionally recurrent fevers, and some edema, although typically in most patients these symptoms are transitory and mild. Nervous system headaches can sometimes be observed, but they're not common. And then there, with MEK inhibitors as a class effect, there is a observation that treatment may decrease ejection fraction of the heart. Typically, that is reversible, but it needs to be monitored, and we are still collecting data on the long-term effects that the treatment might have on cardiac output, if any. And ocular side effects, including blurred vision, photophobia, can also be encountered with MEK inhibitors. Some more serious retinal toxicities have been reported in subsets of patients. They're fortunately quite rare in children, but it is important to pay attention to any new ocular symptoms, and if necessary, refer for an urgent ophthalmological evaluation.
Yeah, there's some, if I may interject,
Yes,
Dr.
please.
Karajannis, there's some interesting patterns that we see with these toxicities. Early on in the course of administering MEK inhibition, we see those abdominal complaints more frequently, and those tend to improve after the first few months. As well, we see age-related difference in toxicity. So in young children, the skin toxicity tends toward more dry skin, eczema, whereas post-pubertally, we see more of the acneiform rash. And I think in both patients, it's really important to anticipate that side effect. And if supportive medications are initiated, even at the same time as initiating MEK inhibition, we can obviate the need for drug holidays or dose reductions quite effectively.
Thank you for bringing this up. That is extremely important because of the toxicities and the fact that most of them are manageable. It is very important, as you pointed out, not to simply prescribe this medication and then send their patient on their way and tell them to come back in a month. This is not a good strategy, and so it requires a lot of teaching, some of which and education, some of which we're trying to provide today, and ideally, as we discussed, to put together a multidisciplinary care team, if possible, so that the education and the mitigation of side effects can be done in a most optimal way. And yes, you're absolutely right that this will avoid frustration. This will avoid treatment interruptions, and toxicities, and help sustain and increase the chances of success with this treatment. So, since
Dr. Karajannis,
yes,
we have a
please,
question.
yes,
That's preferential. Sorry to interrupt. So
yes,
what are the best strategies for balancing effective symptom management with minimizing long-term treatment-related side effects?
Would you like to answer that?
So sure. So I think they go hand in hand. So I think it's an ongoing discussion looking at the symptoms, side effects from the medication, and it's really a dialogue between the multidisciplinary team, the patient, and the patient's family, and to minimize both short-term as well as looking at the potential for long-term toxicities. So really those, from what we're seeing based on data, are referential to cardiac toxicity, which again, you stated beautifully, is typically reversible with dose reduction or cessation of medication. And then of course the retinal toxicity, which we see very infrequently in children. But we want to make sure we're monitoring for that, because those are the potential for long-term treatment-related side effects. But it's really an ongoing dialogue between the patient family, and the multidisciplinary team to minimize side effects.
Well, thank you for clarifying this. And, I could add that, in terms of long-term effects, these drugs have only been around for about a decade or less. And so we do have limited data of long-term safety, especially in young patients. However, on the upside, we have not really seen safety signals to suggest that there is a major risk or significant risk in, with rare exceptions, for long-term toxicity that would significantly affect health or quality of life. Of course, with a caveat that we do not have very long-term follow-up safety data available at this point.
The FDA indication for selumetinib in particular, because that's the one that's FDA approved, is really for indefinite use as long as the patient is deriving benefit. So I think that does empower us as physicians, as caring physicians, to utilize the medication as long as we think the patient's deriving benefit. But I think it's really important to have an ongoing dialogue with the patient and their family about what they're experiencing.
I would very much agree. The treatment is safe and effective long-term in many patients. But we also need to constantly think about, is it time to stop treatment perhaps? Because there are toxicities and other issues. So I fully agree with you. It needs to be an ongoing discussion. And I see another question in the chat here. How do you address challenges in patient adherence when transitioning between pediatric and adult teams? And I'm happy to take that, because that is something that we do at our center. We have an adult NF expert who typically takes over patients that are seen on our service when they reach a certain age. But we make it a very tailored approach, depending on the patient situation, the family, the medical, the medical team that the particular patient has. So I think it's a great question, because there are challenges about how to transition patients from one team to another, and that doesn't not only goes for NF, that goes for many other chronic diseases and chronic conditions. It depends on the circumstance of the patient. Again, it depends on the specific care team that the patient has assembled, sometimes over many years or sometimes decades, and then figure out what is available, and how should they transition, and which parts or members of the care team should be transitioned when, because different physicians have different ages of patients that they are willing to see. So it gets very complicated, and there's certainly no one size fits all. It really needs to be a customized a plan to be developed with the patient. The good news is that rarely do these things have to be done overnight. So usually there's time to think about this and do it in a deliberate way. So we're seeing here the QR code has appeared on the screen that you may scan to claim your CME credit. So very important, and we've got that up now. So we already talked quite a bit about supporting patients and families, whether they are receiving a MEK inhibitor or other therapy or no therapy, and are followed only expectantly. Education, of course, is important. We're trying to provide some of this today, and that includes education of both the patient and their family and their caregivers, but also, of course, education for us as physicians or other providers who help take care of NF1 patients. And fortunately, over the last years and decade, we've seen a significant increase in practitioners who are interested and knowledgeable regarding taking care of NF1 patients. And many hospitals across the country have built increasingly sophisticated NF centers, in the sense that they've come together with other providers to provide comprehensive care for NF1 patients. And so for many patients, this is an opportunity to receive care by a multidisciplinary care team that is specializing in NF1. There are challenges in many areas of the country that are medically underserved in general, but specifically for NF, that is an issue, and that's something that we need to try to address in the future. On a patient level, local advocacy groups can help provide peer connections and foster resilience. Many NF1 affected individuals take advantage of these local advocacy groups. There's many ways to get involved in the community. And then, of course, last but not least, digital platforms such as the one we're using today to provide resources and support. And here's another question. How can clinicians better incorporate patient and family preferences into treatment plans for NF1? And I'm going to give that to you, Cynthia, if you would like to answer that.
Of course. I think that this is an ongoing conversation. As you mentioned, Dr. Karajannis, we have the benefit of time often with NF1 and plexiform neurofibromas to really have thoughtful discussions with patients and families about what their goals are, about what the patient is experiencing, and what their hope is for medication moving forward. So I think it's really important to listen and to provide lots of opportunities for dialogue. And really, I think this addresses the compliance issue that we were asked earlier. Because if you get the buy-in from the patient that this is really helping her or him, you'll get that compliance, and you'll be best able to address the patient's specific questions or concerns or needs if we're really listening.
Thank you, Dr. Campen. These are very important points, and I think a lot of it goes back to good doctoring, right? Being available, listening to the patients and their caregivers, and coming up with a very personal plan, and then help to put that plan into action. Thank you very much.
Well, thank you. This has been such a fun discussion.
Likewise, thank you so much, and thanks to the team. And thanks to the audience for listening, and hope you've enjoyed this.